Hi friends, welcome to Charcos. I'm Dr. Seema Balian, the founder and director of Charcos. Charcos is a healthcare recruitment and training company with over 15 years of experience in providing turnkey solution for training and recruitment needs for the nurses, doctors, and AHPs such as radiographers, occupational therapists, ODPs, and many more. OSCE training for all fields of nursing such as adult nursing, mental health nursing, pediatric nurses, midwifery, and learning disabilities. OSCE training is available in India as well as in UK. Orientation for life in UK, OSCE exam bookings and the logistics bookings, excellent pastoral care. Our state-of-the-art learning platform includes reading materials, videos, quiz to enhance your learning and equip you for a positive and a better outcome. For more information, please visit our website www.charcosglobal.com. Our Facebook page, Instagram, and LinkedIn pages by the name of Charcos Global, and subscribe our YouTube channel. Press the bell icon for regular updates and all the information that you require. We are looking forward to seeing you on our site and being a partner in your enhanced journey. Thank you very much.
So, Doctor, whilst waiting for Priscilla,
Yeah.
I know that some dummies are having, like with the pregnant dummies, the baby that are in the dummies, like you are able to listen to the auscultate the fetal heart rate. So the one that we are going to do, are we going to able to auscultate the heart rate too?
No, but you might be required to show that how you are going to be auscultating. But I don't think that you will be able to hear anything. The examiner is going to give you the reading.
Okay.
Yeah. But you will need to demonstrate with the PINADs, or if they give you the fetal Doppler, you will need to say that this is how you are going to, and that is going to be the part of that when you are checking the lie of the baby. And then say if it is like a left lateral lie, if the baby is there, then usually you will be auscultating on the left side, because that is where you will be able to hear the fetal heart sounds in the best manner.
Okay. Thank you.
Priscilla, can you see the screen now?
Yes.
Yes?
Yes, I can see.
Okay, great. So we will start then. Okay, so welcome back again. So we are continuing the rest of the scenario. So yesterday we did the normal birth and the birth scenario 1, which was the shoulder dystocia. So today we are going to be doing the birth scenario 2, which is the PPH. Okay, so before we start this one, yesterday we did discuss a little bit about the PPH and what could be the reasons or abnormalities of the placenta and all that. And that can be one of the reasons, but can you tell me that what do you understand by PPH, and what could be various reasons of having the PPH?
All right. When we talk about PPH, it's a excessive bleeding followed by delivery of birth, and this can be happen to consider 40s. So with the 40s, we have one as a one being the tone. The tone is as a result of ineffective uterine contraction for the uterus to contract. That is why there is bleeding. And 2 will be as a result of trauma. The trauma can be on cervical, undiagnosed cervical tears, or undiagnosed cervical tear or perineal tears. And tear can be the thrombin. That one will be as a result of clotting disorders. And the last one is tissue. The tissue will be as a result of retained products. Yeah, that
Well
is what
done.
I know about PPH.
Yeah, well, you pretty much know everything because that is exactly those four things, the reasons. And we will be in this scenario, we will be going through all those reasons and we'll see that what can be done. Yeah, so I think that is great that you have put it out. So if we are looking for the definition, as you mentioned, that it is the postpartum hemorrhage is a severe bleeding after giving birth. And because there is a lot of blood loss and lots of bleeding, it can be quite a serious and a dangerous condition and needs to be treated like an emergency. So although we can see that normally if a PPH has to happen, normally it will happen within the 24 hours of childbirth, but it can happen at any time later as well. So I have seen people that who have been discharged and everything, and they come back in a week's time with severe bleeding again as well. So that can also be considered as the PPH. And there might be any of these four reasons, which to start with, they might have not shown as a PPH, but later on they presented as a PPH. So we'll need to be aware that it is not that in the next 24 hours that we have to be careful, but we need to make the female aware of even after that as well, that if she gets any excessive bleeding, even after being discharged, that they should report. So otherwise, like if we see from the volume point of view that what do we considered as a PPH is usually if we have to give it a volume, then it is like 32 fluid ounces or maybe approximately 950 ml or close to 1 liter kind of a thing, that after delivery, if that much is the blood loss, then usually it is the PPH that we would be saying. Even I think that is more of like to if we have to give a number, but probably even slightly lesser than that would also be considered as a PPH. But this is something that we would say that from the definition and from the book point of view that we will consider that. And this could be dependent on either whether it is a vaginal delivery or whether it is a cesarean section. It does not matter how this blood loss has happened. If that much is the blood loss that has happened, then that will be considered as a PPH. Okay. So then if we are looking at that, what are the types of PPH, then there can be two types as what we have just discussed, that if primary and secondary. So if it happens within the first 24 hours, it is considered as a primary PPH. But if it happens after 24 hours to any time 12 weeks postpartum, then that will be considered as a secondary PPH. Now, the causes of the PPH, as you have, Masi, as you have very nicely sort of said, that it is the 4 T's that we have to be aware of. And the 4 T's are, as you have said, the thrombin, tissue, tone, trauma, and then there can be sometimes there can be some other factors as well. So if we look, and I'll bring it slightly more that you are able to see it. So if we look at all of them, then thrombin. So can you tell me that what do you understand by thrombin? That what is thrombin? Priscilla, can you tell me that what is thrombin? And why is thrombin important? So tell me what is thrombin or why the thrombin is important. Why would thrombin lead to a PPH? Okay, Mercy, you can tell if you know.
Hello?
Hello.
Yeah. Either of you, if you can tell me that what is thrombin.
Line is breaking.
Yeah, I can hear you now. So you can tell me now.
You said why would it lead to PPH?
Sorry, say again.
I didn't get what you said.
I was asking that since thrombin is one of the reasons for having PPH, I just wanted to know that if you understand what is thrombin and why it should be the reason for PPH.
Okay, I think if the blood is unable to clot,
Mm.
it could lead to the woman bleeding excessively, which can lead to PPH.
Yeah. Yeah, no, that is absolutely right. So basically, thrombin, it is a clotting factor. Yeah, so thrombin helps to for the blood to clot, and it is something that is going to convert the fibrinogen into the fibrin, which are like when how your clotting actually happens. So if you are having any kind of a clotting disorder in which thrombin, so if thrombin is not there, then the clotting is not happening very effectively. And that is the reason that even if there is a small amount of bleeding, but if you're not able to clot and stop the bleeding will continue, and that can lead to the PPH. So that is the reason thrombin is very, very important. And thrombin can be affected in either if you are having some other conditions like preeclampsia, placental abruption, or having temperature when you are in labor. But there are some bleeding disorders as well, like hemophilia or the von Willebrand disease, or if you are taking some anticoagulants and all that as well. So we need to be aware that if there are any of these reasons or anything which is there, which might leads to the lack of thrombin and hence the PPH. So hopefully, if they are very like the planned deliveries and if the good antenatal care has happened, then we would already know in advance that if there is any bleeding disorders or if there is any other risk factors which are there. Okay, so that is thrombin, the role of thrombin. Then we come to tissue, and when we say tissue, then basically it is that if there are anything which retains inside the placenta or inside the uterus, sorry. So it could be a retained placenta. It could be a placenta accreta. Now, you remember that yesterday we spoke about what is placenta accreta? Can you just quickly remind me that what is placenta accreta?
Yesterday we said placenta accreta it happens when the placenta has deeply embedded in the uterine muscles. Yeah.
Absolutely. So if it is deeply embedded in the uterine muscle, so it is quite possible that all of it does not come out when the placenta is delivered. And that will, the whatever has been retained behind, that will not let the muscles to contract. And if the muscles are not contracting, the blood vessels will still be open because they have not been contracted as well, and the bleeding will continue. So it is very, very important. It can be important cause of having the PPH. And then the retained product of conception. So anything which stays behind into the uterus, which does not allow the uterus to contract completely, is going to end up leading to the PPH. So, and that is where what we were discussing, Mercy, it is very important that we pull out the last bits of placenta as well in order to make sure that there is nothing left behind and the uterus contracts completely. Yeah. Then we come to tone. And tone is, of course, by tone, we mean that the uterus should be able to contract completely. So it should not be atonic, or it should not be lacking that hardness, because that is very, very important, that when it contracts completely, that it will just contract the blood vessel as well, and it will squeeze the blood vessels and they will stop bleeding. And there are certain reasons that why there can be a problem with the tone. So if there is the placenta previa, then that can be the reason that the tone of the uterus might not be as good. If the uterus is over distended, like in the multiple pregnancy or polyhydramnios or microsomia or a big baby, then that can lead to atony of the uterus. If we have given any uterine relaxants that are there, then they can also lead to the atony of the uterus. And if there is a history of previous PPH, so if there is a history of previous PPH, then probably one of those things would have happened before as well. So there is already a known reason that why it should be. So it is very, very important. And I think that if we had to say out of all these four, probably the tone is the one which is the most important one and which is the most common one as well. So it is important that as soon as the baby is delivered, and that is like when we were going through your steps of the criteria, we read that as soon as the baby is delivered, that you should be giving the syntocinon to the IM syntocinon injection, so that to increase the tone of the uterus, because that is going to bring the tone and hence quicken the delivery of the placenta as well as then contract the uterus. Yeah, and then the last T is the trauma. And of course, any kind of trauma would lead to the PPH. So the traumas are, again, normally the traumas can happen while the cesarean section. It can also happen when you are giving an episiotomy. That can also lead to a trauma. Maybe you might just, there is a big blood vessel or something which might get injured. Microsomia is that if the baby is more than 4 kg, so during the delivery, it is quite possible that there is some trauma to the uterus or some other parts or during the delivery, and that might lead to the excessive bleeding and hence the PPH. And then there are few others as well, which are also, which can go with that. So Asian ethnicity is somehow it is more related with the PPH. Anemia, if we have induced the labor, that can also increase the risk of PPH. If the BMI is more than 35, then that is also a risk factor. Labor, if it is prolonged, and if it is the age, the more the age, the higher the risk of the PPH. So these are some of the reasons that of the PPH and why it happens and causes. So we need to be absolutely aware of all these causes and try and sort of preempt these causes and then try and take the actions much in advance to make sure that the PPH is avoided at all costs. Yeah. Any question in this one?
No.
Okay. Okay, then looking at now that we know what are the causes of PPH, we want to now have a look at that. What are the signs? How do we think that, or how do we check that there might be PPH which is happening? So obviously, they are going to be the signs which are similar to the signs of excessive blood loss from anywhere. So you will get like a hypotension-like feeling where you will get dizziness, blurred vision, feeling faint, and actually you will have hypotension as well. The blood pressure will go down. The heart rate will go up. If you are able to do the blood, then you will find that the HB is, the hemoglobin is low. The patient will look very pale and clammy, nausea, vomiting, and of course, depending upon what the reason is, there would be worsening abdominal pain and pelvic pain as well. So, but all these things, they happen pretty quickly because when there is a PPH, normally there is a lot of blood which gushes out very quickly, and the symptoms can very quickly worsen. So we have to be very much aware that there is a possibility and this could happen, and we have to be ready with what actions we are going to be taking. So early recognition and management is very, very important. So now coming to the management of the PPH, then of course we have to first and foremost, we have to make sure that we understand that this is an emergency situation. And like in the shoulder dystocia, like yesterday we said that it is important that we are going to be calling for the multidisciplinary team and calling for help. We are going to be making sure that we call for help. And over here today, it is going to be a SOAS as rather than SOAPs, it is going to be the SOAS as your mnemonic, because the baby is already delivered. We don't need a pediatrician over here. So, but we will need the senior midwife, senior obstetrician, anesthesiologist, and some other people as well, so that they can help and support in various ways, whether it is documentation, whether it is talking to the family, talking to the female, or helping out with other sending bloods and all those things. So we need some other people as well. Then again, very important to explain the situation to the woman and reassure. We'll need to also start oxygen. So we'll need to treat it like an emergency situation, and we'll need to act on all those things. So start the oxygen. It is going to be very important to find the reason of the hemorrhage or the cause of the hemorrhage, because if you are able to find that one, then you will be able to target your treatment toward there. So very quickly, you'll need to check that whether it is the tone, whether it is the tissue, whether trauma, or whether it is any kind of other reasons for that one. So quickly, we'll have to figure that one out. Try and rub in a contraction, because as I was telling you, the tone is one of the most common reasons for this one. So have you, both of you, have you ever tried to rub in a contraction? Do you know how to do that?
Yes, please.
Yes.
So how do you do that?
Massage the uterus.
How do you rub in a contraction, or how do you make sure that you stimulate the uterus for the contraction?
You massage the uterus with your hands.
How do you massage it? What are the various ways of doing it?
I don't know how to describe. Mercy. Mercy.
Why are you calling me? Suffer your own suffer. So, doctor, please, what I know is that you use the inner part of your palms. Then you massage. Let me say, this is the uterus. So you put it there. Then you massage. Then you try to aid contraction of the uterus and also expel the clots.
Yeah, which is see, there are two ways that how we can do it. One is the external sort of massage, and then the internal one. Now, the external massage, which you are telling me, that is right, that yes, you are going to be rubbing the stomach, you are going to be rubbing the uterus externally and try and sort of bring the contraction, and hence the uterus will contract. The other way is also that you can do an internal massage by doing the PV examination. So you are actually massaging the uterus from inside. Yeah. And I know, I don't know whether you have ever done it, but I know that when you are massaging the uterus like inside, you will feel the uterus to contract and it is like the contraction is actually quite, you will feel the squeeze around your fingers, and you can feel if there are any clots or something which are there, you can take the clots out as well. And simultaneously, you can do an internal massage. You can do both as well, internal and external massage, and remove the clots and things. And that is one way of rubbing the contraction and hence trying to stop the bleeding. Yeah. So then checking for trauma. So while you are doing that, you will also need to do your check just to see that where the bleeding is coming from, whether there is any external area, any external reason for the bleeding to happen. So you will need to check if there is any trauma, and then so that you can act on that one. You will need to site 2 large bore cannula to take blood cross match as well, because you will need to do a fluid resuscitation. Then you might have to do a blood transfusion. So it is very, very important to take the bloods and then to send for cross matching as well. And you will need to also check for any blood clotting disorders and all that sort of thing. Yeah. So then fluid resuscitation. So you are going to start with Hartmann solution or just the normal saline. You will need to start the fluid resuscitation immediately. Catheterization of the bladder. And of course, you will need to be taking all of the observations and plot them on the Meows chart. So these are some of the immediate management sort of thing that you are going to be doing. Ultimately, it is going to be the figuring out of what the problem is and then sorting the problem out. So that is going to be the ultimate way of treatment or of the PPH. But these are some of the immediate things that you will need to be knowing and you will need to be doing as a midwife. So again, uterine massage, we have, so we are continuing with that. Uterine massage, we know that it is going to help. But then along with the uterine massage, we can also use some medication as well to stimulate the contractions. And the medicine can be like oxytocin, misoprostol, or methargine, or any of the prostaglandins as well, depending upon what is the most suitable one. We are going to be giving these medications. Remove if there is any retained placental tissue from the uterus, which we have already checked. If there is any trauma trauma or if we have given episiotomy or something, then we'll need to repair that one, whether it is a vaginal trauma, cervical, uterine tear or laceration. So we'll need to check and we'll need to make sure that those are repaired. Then using a catheter or a balloon to help put pressure on the uterine wall. Now, these are some of the things where we are going towards more of like if all the initial things they fail, and then we are going for the more drastic measures. We know that the bleeding is happening from the blood vessels which are there in the uterine wall. So we need to act and do something that if we are not able to help with our regular measures, then we'll need to do some other measures such as putting a direct pressure on these blood vessels by doing like there is a balloon kind of a thing that you can put, which you inflate, and that balloon puts the direct pressure on the uterine wall. Then it is also another thing, that drastic thing can be the uterine artery embolization. Now we know that all of the blood supply to the uterus is happening via the uterine artery. So if we embolize that artery, that means that we stop the blood supply to the uterus and hence reduce or stop the PPH. Blood transfusion, of course, is there, that we'll need to replace the blood which is being lost. So that is another resuscitation measure that we will be taking. And then, of course, last but not the least is like that if you are not able to, any of these measures, you are not able to control and nothing is helping, then you can go for the hysterectomy as well, the removal of the uterus. Okay, so these are some of the measures that we are going to be taking in order to help with the PPH. Any question that you have in any of them?
Doctor, please, with the uterine massage you were talking about, the internal one, is it the internal?
Internal,
the internal one, is it the same as the bimanual uterine compression?
Sorry, is it the same as what?
Bimanual uterine compression, is it that one?
Yeah, it will be same, because that is again that you are going to, it is the same, that just the different term that what we are using for that one. So bimanual is that you are doing from the external, which is on the tummy, as well as the internal from inside in the uterus. So you are rubbing the contraction both ways so that you can achieve the maximum benefit.
So please, with what you've taught us, should we arrange it the way you've taught us, or I don't know? Because it's similar to what we do back home, but the steps that we take is a bit different.
Okay, what are the steps that you take?
Okay, back in my facility, what we do is that when you get PPH, as you said, we should call for help. We do call for help, and we give oxygen. We give a higher oxygen flow, like
you'll give 100%, 15 liters one,
by using non-rebida max.
Yes.
So with a non-rebida max, then you start to massage the uterus. So when you are massaging the uterus and the uterus is not contracting, then back home is our policy that the cannulas are already there. but you give additional cannula as you stated today. Then you take sample for the grouping and cross matching for clotting disorders, and also we do bedside clotting time, and you pass the catheter immediately. You give the extra cannula, then you pass the catheter to indwelling catheter to empty the bladder. So after that one, then you check the observation to rule out signs of shocks, signs of shock. So after the signs of shock, then if oxytocin, IM oxytocin has been given immediately after delivery, then you start to give either oxytocin or syntocin or ergot. But with the ergot, at times we pay much attention with the BP. If the woman is having high BP, we don't give the ergometrin. Because it increased blood pressure. So with the after giving the ergot, then the doctors will ask, maybe have you given cytotec, that is the mistoprostol. So at times we give the mistoprostol like 800 microgram. So when we give and the bleeding is still coming, then at times we can give tranexamic acid. So like it depends on the case that you get. So if it's severe PPH, at times we give the tranexamic acid if the bleeding is not stopping. So if the bleeding is still not stopping, then like we according to the blood loss, then we give blood transfusion. If it's too much, we give blood transfusion according to the blood loss that we like the vagina loss with weight, then we give the blood transfusion. So after the blood transfusion and nothing is happening, then we try to do bimanual compression by going to the vagina at the anterior uterine wall to apply a fix there. You apply a fix in the vagina, and externally you apply pressure at the fundus to attach and see if the bleeding will stop. So if the bleeding doesn't stop, then you have to take the patient to theater for anesthesia.
Exploration
Maybe if it's placenta, the placenta, if it's aquator, she will be given anesthesia, and the placenta will be delivered they will deliver the placenta manually, or if cervical tear, they will suture. It depends on what will happen in theater. So I don't know whether it's the same method or you can just mix.
No, it is exactly the same sort of thing. Now, the things that you have told, I think that you have told exactly what we are going through. The only thing which I would differ over here, and I'm sure that in real life, probably you'll be doing that before, that the compression of the uterus, probably you will do slightly before you are just starting the blood transfusion, all those sort of things, because if this is one of the reason of the if the placenta is out, and if you are not worried about the placenta accreta and all those sort of things, then I think that it is worth exploring the uterus and doing the uterine massage early on, because it might be just that it was a temporary atony of the muscles, and that was the reason for that. And with just the uterine massage, you are able to achieve the atony and hence stop the bleeding. And then you might not need to go through so much of the other, because if the blood loss, then if you are able to stop the blood loss, then you might not need to transfuse and all that sort of things. So that is the only thing which we will be doing early on. But the rest of the thing, what you have said, are exactly that is how it is going to be done. That is how it will happen.
Okay. All right. Thank you.
So well done. I'm really happy that you have really given all those things. So exactly what you have said, it is going to happen exactly in this way only. And again, coming back to the same thing,
protocol.
Yes. And every hospital has a protocol of how you are going to be doing, but the protocols are not going to be too much different, because there is only these ways to manage. And there might be just a slight difference here and there, which you will become aware of. Whichever hospital you are going to go in, you will be aware of that what protocols they are using. But you have covered all of the things. So I don't think that there is anything that you have left. This is exactly how it is going to happen.
Okay.
Okay, Priscilla, is there anything that you want to add or you want to ask? Okay, great then. So basically then this covers your this station of the PPH and or the delivery stage or the station 2. So now it is possible, and with the way that I'm just saying possible, I think that there is a possibility that this station might actually just be a written station, because in the real life or in the exam, I'm not sure that how they can show that what the PPH kind of thing. So the people who have given this exam till now, they did not get this scenario. So I do not know that whether it is going to be a written station or not. But if it is a written station, then you normally will be given a scenario and you have to write down just all these steps, that these are the things that you would be doing and these are the steps that you would be taking. Okay, so top tips are the same sort of thing that what we have already discussed. So I would want to just take you through again the criteria as well, just so that we can quickly run through the criteria that you know that what is going to be asked. So if you just bear with me a minute, let me bring up the criteria. So this is the scenario birth scenario 2 marking criteria. Can you see my screen, Priscilla?
Yes, please.
Yeah. Okay. So in this one, if you see, then that is the first thing, that we are going to recognize that it is an emergency and call for the emergency the help. Then the other thing is also, like in all of this thing, we have to make sure that the baby is in a safe place, because we don't want the baby to be in between all these things as well. So we'll need to make sure that the baby is in a place of safety, such as a cot, and that someone is looking after the baby as well. So we need to make sure that one. Then you are going to be considering the cause of the hemorrhage. So you'll need to verbalize that what could be the reasons for the hemorrhage. And these 4 things that what we have discussed, like tone, tissue, trauma, and thrombin, we are going to be telling them that these are the 4 things that you will be looking out for, that for the reason for the hemorrhage. Supporting the woman to lie back and commence high flow oxygen using a non-rebreather mask. So this is exactly what you just said, Mercy, that is what we are going to be doing. We are going to rub a uterine contraction. Okay, so this must be demonstrated. So if we are going to demonstrate, then this is not going to be a written station. So you need to demonstrate that how you are going to be rubbing in a contraction. You are going to ensure that the uterus is well contracted and that the clots are expelled. So verbalization is going to be accepted. So over here, the uterine contraction, you are going to be starting with external uterine contraction, but you will need to tell about the bimanual uterine contraction as well, as we were discussing. So that is how we are going to be rubbing in a contraction and to remove any of the clots, to expel them as well, that if there are any clots which are there. Then checking the placenta, that you have to again say that you would have already checked the placenta, but you might want to check the placenta again just to make sure that by mistake or that there was not any missing part of the placenta, which might have been the reason for the retained product and hence the bleeding. Yeah. Then you are identifying the need to check for the trauma. So you are going to be verbalizing that I will be checking for the trauma by doing a thorough perineal examination, just to see that whether there is any trauma in the external trauma that you can see, whether there is any trauma inside the vagina or the cervix. So there can be a tear. It could be the episiotomy site. there can be a tear in the vagina or the tear in the cervix as well. So you will need to see, and you will need to see that if you can visually actually see the bleeding coming from the trauma. So you have to verbalize these things. And then you are going to be verbalizing that, yes, you are going to be putting the 2 large bore cannula, one in each arm. If there is already one, that is fine. Then you are going to put one more. And you are right, Mercy, that majority of the time, the cannula will already be in if it is delivery that is happening in the hospital and not an emergency delivery which has happened. So you are going to cite or going to make sure that there are 2 large bore cannula which are there. Then verbally, you are going to also be saying that you will, while citing the cannula itself, you are going to be taking the bloods, and the bloods which you have said that we are going to be setting for clotting, we are going to be sending for cross match, and we are going to be checking for the clotting times and all those things. So whole of the clotting screening, that what we are going to be doing. And we can do some full blood count as well, just to check the hemoglobin and the anemia and all those things as well along with that. Then you are going to be, so you will need to state that which bloods you are going to be taking. So please say that these are the blood samples that you are going to be taking. And then that you are going to be starting the fluid resuscitation using either a Hartmann's or a normal saline. Catheterization, which you have already said. And of course, all of the physiological observations are going to be taken to say the indicator of shock, like low blood pressure, high pulse, and high respiratory rate. All these things you are going to be checking. Then verbally, you are going to be considering appropriate medication to stop the bleeding. So the medications also, like Mercy, you had said, all of the medications, you are going to be considering those medicines like oxytocin, or like it might be that you might need to start the drip as well for that one. You might want to give tranexamic acid as well. You might want to try the misoprostol or the ergometrin, depending upon the blood pressure and all those things. So you are going to be deciding that about the medication. Now performs bimanual compression of the uterus, clearly verbalizing the appropriate steps. So you will need to probably show this as well, that the bimanual compression of the uterus. If nothing else is working, if your external rubbing of the uterus is not working, then you will need to show that the bimanual compression of the uterus. Now, have you done the bimanual compression, Mercy or Priscilla? I'm sure that the way that you were describing, you must have done it.
I did once. I was not even
Okay.
supposed to do, but I have to do it.
Yeah. So obviously rubbing, so you go in and you are going to actually make like a fist. Yeah. And you will just rub the uterus from the top, you are going to rubbing, and inside you are going to be rubbing, and actually just see, and you will be able to feel the uterus really contracting on your fist when it is working and when it works fine. Yeah. So that is how you are going to be rubbing. And of course, you can see that if there is any clots or something that will come out while you are doing that one, and that is also going to be quite helpful. And what, like verbally consider other options which you might, so other options which we discussed, like doing the till the like uterine artery embolization and hysterectomy and all those things, that we are going to be considering them as well. Yeah. And then the importance of the, of course, telling the woman what has happened, and making sure that, because see, this is going to be a sudden crisis which happens in a sudden kind of a shock to the lady as well. So we need to make sure to keep her informed that although this might not be the greatest of experience to go through, but this experience should not affect the bonding of her with the baby, and it is it does not become like a very traumatic kind of an experience for her. And you'll need to obviously put the importance to the maternal observation, and then also say that you will need to estimate or weigh that blood loss. Now, by weighing of the blood loss is usually you will be weighing that what all of the swabs that you have used to stop the bleeding. So normally you will be weighing those blood swabs, and that is going to give you an idea that how much is the blood loss been. Okay, and the meows chart, we are already going to be documenting the meows chart and the relevance of that one. So we have covered all of these things, and as you were saying that we will need to go step by step, and we will need to just say all the things which you, Mercy, you had anyway, you gave a list of all the things. So I think that you'll have to just follow that protocol itself, and you will need to just go and say those things. Majority of the things are just verbal, so you will just need to verbalize all those things. So any questions that you have in the PPH?
Hello, doctor. Please,
Yeah.
with the OSCE, when it's
Mhm.
come to the practical aspects, is it advisable to verbalize everything? Because I fear that maybe if you don't verbalize everything, there may be like a sentence you need to do and you just forget. So I don't know whether it's advisable, whether it's verbalized or non-verbalized. You just say everything, you go your way, in order not
Absolutely.
to.
See,
Yes.
you have to say all of the things. Now, again, I'm not saying that you have to say exactly in the way that what has written in your criteria. Yeah, it
Okay.
might be that maybe you say one thing before the other. It doesn't matter. Yeah, but you like the way that you told me when I asked you that how do you do it in your hospital? Like you told me all of those things one after the other. The only thing is that I told you that probably you would want to do the bimanual compression before, so that just before you reach to the blood transfusion and all those things. So that is the only thing which I suggested, because in real life as well, it is going to happen before we are waiting for the cross match to happen, for the bloods to come. We are not going to be sitting over there. We'll do the bimanual compression at that time. So it does not matter. Get in a habit of saying out all those things. And anyway, when you are going to be coming for the face-to-face training, we will make sure that we will get you to practice this one. That, okay, tell us what are you going to be doing, show, and you will get in a habit of saying those things. But for the exam, it is very, very important to get in a habit of verbalizing everything, because what is going in your head, the examiner will not know. Yeah, even though you might be doing something, but why you are doing it, what are you doing, what is the purpose of that thing, you will have to verbalize those.